Welcome to class. This welcome video is to the online version of the HS44 Effects of Drugs and Alcohol on the Body and the Brain. It's meant for students who are enrolled in these classes which have suddenly been moved online. If you've stumbled into this by accident, you're certainly welcome to look at all of the videos in this series, just that you will not be receiving specific academic credit for them. In this agenda, I want to talk about first the syllabus. The syllabus is always posted online, depending on the school, either on Canvas or Moodle. For specific information on your class, look there. The rest of this PowerPoint will be an introduction to the field of counseling and some of the things you need to do in order to do well, get the grades you're interested in the class. The topic of this class is the effects of drugs and alcohol on the body and the brain. I am David Joel Miller. Some of this material was originally featured in blog posts on the counselorssoapbox.com blog. The photos are all from pixabay.com or Wikimedia Commons and licensed under the Creative Commons no attribution required license. Normally, in my in-person classes, I ask students to introduce themselves. This probably won't be possible for all of the online classes, but whenever I ask people to introduce themselves to me, I feel I owe it to them to do a little bit of introduction about myself. I'll try to be brief. I am licensed in California as both a licensed marriage and family therapist and a licensed professional clinical counselor. Before I became licensed in those two master's level counseling and therapy professions, I began my career as a substance abuse counselor. I have been teaching at Fresno City College since 2008 up to now, and I am adjunct faculty at Alliant University, where I teach chemical dependency classes in their master's in clinical counseling program. I'm a past member of CalPIC's board of directors and served on both their legislative and ethics committees. I've worked in both residential and outpatient drug treatment, locked psychiatric hospitals, a children's crisis unit, a Department of Behavioral Health's Pathways program, which was largely dual diagnosis co-occurring. I see a few clients in private practice, though these days most of my time is occupied as a writer. I have 6 books that have been published on Amazon, and I blog on the counselorssoapbox.com blog. Recently, I've begun converting a lot of my materials to videos, and this is one in that series of videos. This is a grading scale that's typical of what I use in my human services classes. If you're enrolled in one of my classes, please check your class syllabus on your school's website for the exact details of your grading scale. Typically, I offer points for classroom participation, in this case 10 points. I believe it's important for students to read the textbook and come prepared, ready to talk about the topic and to discuss their questions. I give 2 quizzes, one halfway between the beginning of the semester and the midterm, and the other about halfway between the midterm and the final. These are to test what the student has learned at that point, but also I help in preparing for the midterm and the final. And you'll see that the midterm is worth 50 points, the final worth 50. I've highlighted the paper in red, and I typically do this in the PowerPoints I've used in class, because the paper is really, really important. A lot of students say, why do we have to do a paper? The answer is that for classes at the community college level to readily transfer to a 4-year school, there has to be a performance requirement. And in academic classes such as this, it has to be a paper. So before we're done with this introduction to class, I'm going to give you a brief description of how I would ask my students to write a paper. In my way of thinking, the hardest grade to achieve should be the W. My goal is for students to demonstrate how much they've learned between the beginning and the end of the class, rather than to ding them for what they don't know. So if someone wants a W, they need to get over to the registrar and drop the class right away. If they wait too many class meetings, it may not be possible to get that W, and then they would have to accept the next best thing, which would be the F. To get an F, they need to be below 119 points. The easiest way to do that is simply either skip the midterm or the final or the paper. Skip two of those three, and you're pretty well guaranteed an F. Should you do all of those, even though you have very low scores, the total points for all three of those are likely to exceed the 119. Students who want a D, which is the next hardest grade to get, simply need to skip either the midterm, the paper, or the final, any one of those three, and then they will be below 150 points and will get the D. However, students who typically come to class, take the quizzes, take the midterm and the final, and turn in a paper, even if that paper is a failing paper, still they're likely to accumulate more than the 140 points and end up with a C. Students who do all of the work and put some effort into the paper usually will be stuck with a B. And for those students who are really obsessive compulsive and not only come to class, do all the work, but actually study for the quizzes and tests, they frequently end up with the least difficult to achieve grade, which is the A, which simply means they did everything that a reasonably good student should do. I frequently have students, many of my students are adults, they have families, they have jobs, and life interferes. In these times, we don't want people coming to class if they're sick. I had to make a consideration for people who needed to miss the quizzes. So because there are two, what I did was there is one makeup usually given 2 weeks before the final. For either one of the quizzes, it will substitute. But to be fair to those students who take both quizzes and then take the makeup quiz, if you take all three, I will drop the lowest of the three. There's an extra credit exercise, an experiential exercise described in your syllabus. Typically, that would be to attend an AA, NA, Celebrate Recovery, or some other self-help group. During this time of the coronavirus, and we don't know how long these online classes will continue, I am also accepting that experiential exercise if they attend an online self-help group, as long as it is something that I approve of. All of the classes I teach require a paper in the APA format. There's a good reason for that. Many of my students are returning from having been out of school for a long period of time, or their first semester right out of high school. One of the important considerations is that for these classes to transfer from a 2-year community college to a 4-year school, there must be a performance requirement. In an academic class, that performance requirement is typically a paper, and in the field of counseling or therapy, it has to be written in the APA format. In APA format, and I'm only expecting beginning students to get the rudiments of this, they will get better at it as they progress through bachelor's and master's programs, but in APA format, a 6-page paper requires 8 pieces of paper. It begins with the title page, which doesn't count as one of the 4 pages. Then there is an introduction, why you were writing about that, followed by a discussion. Sometimes that introduction could be scope of work if it was research or some other introduction. Then there would be 2 to 3 pages of discussion. Typically at the end, towards the end of the 4th page of text, there would be the conclusion, What did you discover as a result of researching and writing this? In APA format, it is very important that the bibliography, the references, be in alphabetical order. Many students struggle with this. We do not use footnotes. We use in-text citations, such as Smith, 2010. Some students struggle with this because they learned the MLA format for writing papers in high school and have difficulty adjusting to writing in the APA format. There are many websites available today, some much better than others. You need to pick them well. And I do accept students' use of websites, but they must cite them fully and correctly, not just with the URL. Every web citation must have a date cited in the citation. Here's a very simple layout for a 4-page APA format. Page 0 is actually the title page. I picked a facetious topic. Generally, in my drug counseling classes, I ask students to take a deeper look at one drug and often see if there's a connection between that drug and a specific problem. It could be a medical problem, it could be a psychological problem, it could be a social or relational or societal problem. So here's my example. Why do meth users have bad toenails? Haven't ever seen a paper on this, but it made a good example. Student's name, the class, the semester, and the year. Some students include 4 and my name as the professor. There should be an introduction, why you are writing the paper. And do not say you are writing a paper to prove X, Y, Z. The minute you do that, we know it's not an unbiased paper and that you already had the opinion before you began the research. Also, don't talk about yourself, but talk about the topic. Often students begin with, because a relative of mine had a problem with this drug, I decided I was going to learn all about this drug. And they go on for the first whole page describing why it was important for them to write this paper before they ever get done with that throat clearing and begin to actually write the paper. Following that, and sometimes it's also on the first piece of paper, or page 1, you begin the body or the discussion. On page 2, there will be more discussion. Note there are no footnotes. You use citations in text citations. Meth causes toenails to grow fast, parentheses, Adams, 1913. Not a likely valid citation since meth was not in use at that date, but it's a good example. Page 3 would continue with more discussion, and at least once on every page you need to have a citation. There is no evidence that meth causes excess toenail growth, Brown, 2014. Page 4 of your 4-page paper in APA format would include some more discussion. I've given the example, the idea that there is a connection between meth use and toenail growth has proven to be a myth, Walensky, 2048. Possibly, if the paper ran 5 or 6 pages, and those at graduate level typically do, there would be more discussion on both pages 5 and 6. And then on the last page, now this is after you stop counting your pages of text, you get your sources or bibliography. Notice that I put them in alphabetical order by the author's last name. So Adams, Brown, Walensky, and Z all are occurring there. You see different types of writings and where they might have come from journals, or the last one where it was found online. Plagiarism is a serious academic violation. I know in popular blog writing, it's often common for people to pass on information they read somewhere without giving the exact citation. But in an academic paper, it needs to have the citations. A lot of people were misled when they were taught about plagiarism in school. sometimes elementary or middle school, in which they came away with the understanding it's plagiarism if you use exactly their words. So if I reword the sentence, then it's not plagiarism. At an academic level, the truth is that plagiarism is not only using someone's exact words, but basically stealing their idea without giving them credit. So if you are going to talk about someone's theory, make sure you indicate where you read about or got the information about that theory or that fact. Another problem occurs when people include statistics in their paper, and they say 97 out of 100 alcoholics, and they go on to tell me something. If you do that anywhere in your paper and have statistics, either you need a citation to tell me where you got those numbers, or I need a list of all 100 alcoholics you interviewed and which ones said that it applied to them. Don't use statistics without citing sources. Don't use complicated theories or technical information without telling us where you got it. Sources are important. Use good ones. Good quality sources make for a good paper. Use professional articles, preferably in peer-reviewed journals. I do allow my students to cite or use web resources. As a blogger who has published almost 1,700 posts, I kind of feel like I need to let them use other bloggers' posts. But I ask them to evaluate whether that person has any professional credentials that qualify them to know about this. But it is a great frustration to see how many people use web resources and do not cite them correctly. All they give me is the URL. So next comes an example of how to correctly cite a web resource. Here's an example of how to correctly cite a web citation. And forgive me, I've forgotten where I got this from, or I would give them the credit. But here's the example. Lynch, T, parentheses, 1996, that's the publication date. DS-9, Trials and Tribulations Review, retrieved October 8, 1997, from the Sci-Fi Bradley Science Fiction Club website, and then the URL. Do not simply give me, or give any professor, a URL where we could go to it. One problem with students don't recognize with using web resources and URLs is that these are frequently revised and websites crash or go taken down or the article is deleted. So you cite a website, I go and look for it because I think, wow, that's interesting, and I don't find it. What does that mean? Did you make this up? One of the ways that you do cover yourself for using web resources is to include the date retrieved. There are programs way back that allow you to look back, and I can ask that program, what did this Bradley Education Campus Org website look like on the date that the author of the paper cited? I can go and check and then find out the original information. Questions are a very important part of education, and it's going to be a slight problem for teaching in online classes. Online classes can be taught two ways. Synchronous, where we're all online together and I do one class where the students log in and I talk to them in real time. But a lot of the other online classes or materials are asynchronous. The student will log in, you're going to see this video, and then after you're done viewing it, you may have questions. But if you're looking at it in the middle of the night, forgive me, I'm in bed asleep. So you may have to submit your questions to an email address, or if you're in Canvas or Moodle, through their systems. And then I will answer these questions and post the answers later. In class, I tell students questions are good. I like questions. I enjoy trying to clarify things and providing the information. But there are times when I'm trying to get through an entire chapter in one 3-hour class, and where we may need to set some things to the side. We call that putting them in the parking lot so that those things wait their turn until we can get to them. If we don't get to them that night, we may need to pick them up at the next time. Some things also need to grow in the garden, and they grow till they're ready for them. One example of that is students often at this point, as we're going through this, begin to ask questions about a specific drug like methamphetamine or alcohol. In order to answer that question, I might need to go through the entire 3-hour presentation on methamphetamine and the 3 hours on alcohol, and then explain how the two are connected when someone uses both. So sometimes I will tell students, hold that question until we get to the chapter on amphetamines or stimulants, and then if I don't answer it, come back and ask me. Why do drug and alcohol counselors need to know about the DSM? This chapter on substance use and related disorders defines the scope of practice for substance abuse counselors. Behavioral addictions are included in this chapter, and drug and alcohol counselors may be called on to treat some behavioral addictions, such as gambling, if they had the training for it. In California, both are within the scope of practice of a substance use disorder counselor. In some states, such as Nevada, there's a separate training and a separate certification or licensure for gambling counselors. It's also important for licensed professional clinical counselors, or in other states, mental health counselors, to know about substance use disorders. Why do they need to know? Well, there's a number of reasons. One is that the schools who teach the curriculum for mental health counselors, included in their requirements for the school's accreditation, is that the major should include at least 3 units of substance use disorder or chemical dependency classes. In California, CalPIC is one of the movers who helped to create the license by getting it through the California legislature. And they strongly recommend this as a part of the curriculum. The Board of Behavioral Sciences also includes this as a requirement. If you don't take the class, 3 units worth, you won't be able to take the exam as a licensed professional clinical counselor. One good reason is that if you go for a licensure as an LPCC, drug and alcohol and related disorders will likely feature in some place on the exam. There's some other reasons why mental health counselors, licensed professional clinical counselors, and marriage and family therapists need to know about substance use disorder. In community health settings, the majority of clients have a substance use disorder regardless of their primary diagnosis. It's like the doctor treating you for headaches but not discovering that you had high blood pressure and a heart condition and diabetes. How can you be treating depression if you're not also treating the issue of the substance abuse, the alcohol abuse? I found that when I'm seeing couples and families, often one or several people have been having an affair with a drug of choice. I describe this sometimes as dating Ethel or dating Crystal, both of which result in affairs with a drug of choice that damage the family system. Next, let's turn our attention to counseling for substance use disorders and chemical dependency. It's important to understand how the field evolved, the professions who are involved in working with substance abuse clients, and their terminology they use, and their beliefs about what causes addiction, substance use disorders, and therefore how we would go about curing it. Originally, there were pretty well 2 schools of thought when it came to substance use disorder. One was that it was a result of a spiritual problem and the treatment should be faith-based. It was treated with prayer and required a conversion experience. There are still a number of programs in this area, Salvation Army, the Rescue Mission, and a number of other faith-based programs. Another view, traditionally, was legal. People who drink too much are bad people. People who do drugs are criminals. And what we need to do is arrest them all and lock them up, and that will put an end to the problem. It's a side note, here in California, over a 20-year period, the number of people in prison increased by 1,100%. All of that behind drug use during our war on drugs and get tough on drugs policy. Presumably, with that increase, California is now the safest state in the country, and there should be no longer any drugs on the street. Every day I see another story about an arrest for drugs. Clearly, arresting our way out of addiction has not proved successful. The next development in the history of treating substance use disorders was the medical model. Psychiatry tends to think of and defines in the DSM-5 as addiction as a disease. Originally, psychiatry's way of dealing with things was to try to treat mental health issues with medication. Talk therapy came from two doctors, Freud and Jung, and Brewer, of course, and there were others, who discovered that by talking with people, they could induce a thinking change, which might change behavior. Also, related to the medical model is psychology. Psychology tends to study the way a normal brain works. I've seen many people become psychology majors only to be disappointed that they didn't learn how to solve life's problems. But a lot of psychology involves working with rats and mice and mazes and testing and learning and how we learn things, rather than treating something such as addiction or substance use disorder. I described this distinction between psychology and therapy as, at some point, the two of them got a divorce. Psychology more and more has been about the way a brain works, what is normal, and how we learn. Counseling and therapy is about how we solve problems of thinking, feeling, and behavior. And certainly a substance use disorder qualifies as a problem in all three of those areas. There are a number of different professions who work in the area of talk therapies. One of those is social workers. This includes both licensed clinical social workers or associate clinical social workers. This group came out of with their roots in the idea of being friendly visitors who used to go about and work with people who were recent immigrants who might need to learn to speak English, need to learn how to sign their children up for school, and so on. Marriage and family therapists are a new development, and in California they were the second profession licensed after social workers. In other states they may have been much later. They include MFT trainees, what used to be called MFT trainees, which is now called associate marriage and family therapists. Trainees are still in school technically, and associates have graduated but are working towards licensure. Then we have licensed marriage and family therapists. In California, the demand for mental health counseling was so great that the majority of marriage and family therapists work with individual clients and may work with serious mental illnesses. In some other states, the number of marriage and family therapists is much smaller, and they primarily work on marriage and family and child counseling. Clinical counselors is the newest profession here in California. In other states, this might be called mental health or counselors. And as a profession, we have trainees who are still in school, associate professional clinical counselors who have graduated but are working towards licensure, and licensed professional clinical counselors. While marriage and family therapists usually work primarily from a systems theory, the idea that the behavior of one person affects other people, clinical counselors, as I see it, work more with the person in context. They're required to take more training in career counseling and in substance abuse than the average marriage and family therapist. Lastly, we have the profession called substance abuse counselors. For a long time, substance abuse counselors developed with a different roots and different background and have a different way of looking at the problems. For a good part of our history, if someone went before a judge and said they were an alcoholic, they were likely to be sentenced to a sanitarium, which is the forerunner of the modern mental hospital. Doctors didn't like to treat alcoholics because they almost never recovered. If you said you were a drug addict, the judge was likely to send you to prison as a habitual criminal. Beginning in the late 1930s, about 1935 to 38, Alcoholics Anonymous and other self-help groups began to emerge. Alcoholics Anonymous was the first, but out of that, other recovery programs have grown out of the 12-step model. In this system, counselors are largely peers, and it was a long time before it moved from being a self-help model to being a professional paid treatment. But still, in the early days, up until very recently, most drug and alcohol counselors were themselves recovering people. Recently, substance abuse counseling has become more professional. We've developed here in California a system of registration and then later on certification. Some other states have licensure with varying requirements. There's also been a movement towards advanced degrees, moving into the area of working with substance abuse or substance use disorder clients. One of the professions that has moved into this a lot recently has been the clinical counselors because of their additional training in substance use disorders. Another movement that has been gaining force is the idea of treating co-occurring disorders. The majority of substance users have a mental health problem, and a very large majority of mentally ill people have a substance use disorder. So we expect the overlap between those two problems to be quite significant. More and more substance abuse treatment facilities are hiring people with master's degrees or licenses to be able to coordinate the co-occurring disorder clients' treatment. It's very important to pay attention to the difference in terminology that the various professions may use. Medical doctors and psychiatrists, and I've had them call me and ask me, is this person chemically dependent? By this, they're largely talking about physical dependency that might cause withdrawals. Psychologists are more likely to stick to criteria, and they may separate people into physically dependent or just psychologically dependent. Therapists, mental health counselors, may also be looking at the DSM diagnoses. If you look at older charts, you'll see when we use the system of defining it as abuse or dependence and intoxication and withdrawals, all four of which had a list of symptoms. We now have in the revised system intoxication, withdrawal, and substance use disorders, which occur on a continuum of mild, moderate, and severe. Substance abuse counselors, many of whom are peers or have been traditionally, are used to thinking in terms of, is this person an addict or an alcoholic? And if the person says they are either of those, then the self-help program has a solution for that. Faith-based people are likely to talk in terms of congregation or beneficiaries, and often ask for a testimony about the person's faith and conversion experience. Law enforcement would think in terms of criminals, have they been arrested, what are their convictions, and so on. Peers, who usually work in the mental health system rather than substance abuse, may refer to people they work with as either consumers, or many programs now use the term clients. There's also huge differences in self-disclosure between the various professions. Medical doctors, psychiatrists, and psychologists frequently do not self-disclose. If you think about Freud sitting behind the couch so that the client he was working with couldn't even see his face and whether he was smiling or frowning. Therapists, mental health counselors, often have very limited self-disclosure. I think that clinical counselors are taught more to use appropriate self-disclosure, whereas MFTs often are taught not to self-disclose or to limit it very strictly. Substance abuse counselors, on the other hand, are very likely to self-disclose because many of them are in recovery. Many of them attend 12-step meetings and are used to introducing themselves as either an addict or an alcoholic. In peer programs, where many people are in mental health recovery, someone might introduce themselves as having schizophrenia or having major depressive disorder and share their story of how their disorder impaired their life and how their treatment has helped them. Faith-based programs frequently limit their sharing or self-disclosure to testifying about their faith and conversion. I see people who attend a faith-based self-help group who are often reluctant to share about their drug or alcohol problems. While they may be able to testify about other things, they may find that they're discriminated against by people who don't understand that substance abuse may well not be a voluntary thing, but may be a disease. And law enforcement often thinks about the person in terms of what were they charged with and what were they convicted of. In my in-class programs, teaching, I would at this point say the reason I went through those professions and their self-disclosure is that I suspect that there are people in this class for a number of reasons. And I don't want people to self-disclose more than they are comfortable with. But I would ask them to think about why have you found yourself in a substance use disorder counseling program, or at least my class in that program. Many of the people who come to that class plan to be substance abuse counselors. Some of them plan to work in the mental health field. Others may be social workers in training or nursing or plan to work in the medical field in some aspect. Often I find students in my classes are there because they have friends or family who have substance use issues and they want to be able to understand it. Sometimes people take the class because they are in personal recovery. And even if they do not go on to work as a drug and alcohol counselor, taking classes like this can be very beneficial for people's own recovery. And then there's always a smattering in a large class of people who are there for other reasons, criminal justice majors or people who just thought it would be a good elective to know something about drugs, people who might want to be paramedics or nurses or so on. So if you're listening to this, I would invite you to think about why you might have watch this video if you're registered in one of my classes, or if it was simply something you're interested in.